And we shall go on to our next speaker, Dr. Shubhangi Bhave, who's a consultant ophthalmologist from Drishti Eye Clinic and Squint Center, Nagpur. And she's going to talk on Duane syndrome tips and tricks for management. On to you, Dr. Shubhangi.
Thank you, Dr. Chitra, for asking me to be part of this wonderful seminar. I'll be talking on tips and tricks in management of Duane's retraction syndrome. I think we'll skip this slide of introduction. Coming to the tips and diagnosis. Basically, the primary, when we need to differentiate Duane's retraction syndrome most commonly from sixth nerve palsy, and the primary position deviation is, as you can see the picture on the left, that there is it is in accordance with the limitation of movement. So in sixth nerve palsy, the girl has a grade 4 abduction limitation, then she has a similar amount of ESO deviation in the primary position. But in a case of ESO DRS, as you can see on the right, that primary position appearance is almost straight with a grade 4 limitation of abduction. So there's no match between the primary position deviation and the limitation of eye movement. That makes us suspect whether it is a Duane's retraction syndrome. And then we have the palpebral aperture changes, marked globe retraction, upshoots and downshoots, which again goes in favor of Duane's retraction syndrome. Certain systemic anomalies can be associated with Duane's, as in Goldenhar and Klippel. Then if we see these epibulbar dermoids or preauricular skin tags, we have to suspect that it could be a Duane's retraction syndrome. It could be seen in families. And then coming to the tips in examination. Most important thing in managing a Duane's retraction syndrome is to assess the abnormal LR innervation. So EMG is the gold standard, but is not available with everyone. Clinically, we can assess the anomalous LR innervation by assessing the retraction of the eye of the globe and assessing the up and down shoot. The more severe the retraction and more severe the up and down shoots tells us that the anomalous LR retraction is more severe. Then we have something called as the forced degeneration test of Ramiro-Apis. It assesses the abnormal innervation of lateral rectus in adduction. In this test, we ask the patient to keep the eye in between the primary position and adduction, and then the temporal limbus is grasped with a forceps, and the eye is adducted, and patient is also asked to see in adduction. So if the anomalous LR activity is there, then one experiences a resistance, and then the patient can be asked to look into abduction, and if there's no tuck, then that shows that there's no action of LR in abduction. So again, another tip is in Duane's retraction syndrome, in order to accurately measure the angle of deviation, it is important to control the fixating eye during measurements. Otherwise, we get a secondary deviation, which is more than the primary. Then coming to certain tips in managing ESO-DRS. In ESO-DRS, normally has a minimal LR activity in adduction, and they have an anomalous LR action in adduction. One has to check for medial rectus contracture by doing FDT as described by Jempolsky. We do, whenever there is a medial rectus contracture, we need to recess the medial rectus, but we recess the medial rectus minimally on the side of Duane's retraction, only to loosen up the force junction test, especially if the co-contraction is more, otherwise it will result in abduction deficit and diplopia in the contralateral gaze. If the deviation is more, then we can recess MR recession in both the eyes. Asymmetric MR recessions can be done to take advantage of We can do asymmetric if we feel. MR recession can be done with SRT, IRT, or partial VRT to improve the abduction if the co-contraction is not severe. Y split of LR also can be done if there is a significant up and down shoot in adduction. Now, this is a patient of ESO-DRS with head posture, and you can see that there is an abduction deficit with some degree of hypotropia. So in this case, the left eye MR recession of 4 millimeter was done, and the other eye MR recession of 6 millimeter was done. And to improve the abduction, an IRT was done to left lateral rectus. So post-operatively, you can see that the head posture is corrected, and there's also some degree of abduction. There's a very short video of superior rectus transposition to LR. Here, the superior rectus muscle is dissected for about 10 to 12 millimeters behind the insertion, and 2 vicryl sutures are applied. The lateral rectus is hooked, and we apply the muscle along the spiral of Tilo, and I had taken an 5-0 with 5-0 ethibond. I've taken a posterior fixation suture about 8 millimeters behind the insertion, and this taking the suture reduces the chances of post-operative hypertropia. Now, coming to the EXO-DRS. In EXO-DRS, there is an abnormal innervation in both medial rectus and lateral rectus. One has to estimate co-contraction. One has to estimate the LR activity. Exotropia with normal LR activity has to be tackled by doing LR recession, as against ESO-DRS, where there's a fear of exotropia and synergistic divergence. Whenever we are doing LR recession, it is never more. So one needs to recess LR liberally. Exotropia associated with up and down shoots and with retraction, it is preferable to do a Y split of LR with recession. We can do supramaximal recession of LR, or if the anomalous activity is too severe, even periosteal fixation of lateral rectus. Always remember there's other eye which can be operated if this eye is not sufficient to tackle the deviation. Now, this was one patient of EXO-DRS who had a significant head posture, exotropia, and a good LR activity in abduction. So we did an bilateral LR recession, and on the left side, a Y split was done, which was done 20 millimeters apart. And post-operative, you can see that there's a good correction of head posture and improvement in globe retraction, and abduction remains good. This is a small video of Y split. The lateral rectus is hooked. In LR, the muscles can be
1 minute remaining, ma'am.
Yes, and it is difficult sometimes to operate these muscles. In Y split, we are splitting the muscle with the Aios and repositor. Then after marking the center of the insertion, I take one mark 10 millimeters below the center. One limb is attached there, and the other limb is again attached 10 millimeters above from the center. The Y split allows us to anchor the globe and thus prevent the slippage of globe in adduction because of tight LR. Then the ortho-DRS, ortho-DRS, it is better not to disturb, the tip is not to disturb the primary position parallelism. We do operate only if there is a significant retraction on adduction. Differential recession of both LR and MR with preferably one muscle on adjustable. And if there is an up and down shoot, we can do an Y split of LR with MR recession. Here is one patient of an ortho-DRS who had a significant globe retraction on adduction. Here I did an differential recession of LR and MR, which corrected her retraction without disturbing her primary position, orthophoria. In bilateral, you treat it as unilateral, and thanks for a patient listening.
Thank you. Thank you very much. That was a very wonderful talk. Dr. Veena, would you like to take some question?
Yes, ma'am. Shubhangi ma'am, do you prefer, like you have done any small angle resections?
No, I have not done, but there was a paper from Murad et al. They say that he does a very small resection of lateral rectus. Normally, we say that lateral rectus resections are contraindicated in ESO-DRS. But if it has to be done, then we have to do very small resection. That is only 3.5. And even the MR recession has to be very small quantity, 4.5 millimeter. But I have not done resection in a case of DRS.
Ma'am, do you modify your Y split depending on the severity of the upshoot, or you follow a standard procedure?
No, I do a 20 millimeters separation in 22 millimeter separation, how much is possible. I don't modify.